Cast is now starting. All attendees are in listen-only mode.
Hello, everybody, and thank you so much for joining us. I'm Katie West-Slevin with Health Policy Plus, and I'm delighted to welcome you to today's broadcast, watch party and panel discussion for the short film, Why Policy Matters, Free Maternal Healthcare in Kenya Saves Lives. We're going to begin with just a few short announcements, a little housekeeping here before I turn it over to my colleague. This webinar is being recorded, and we will have it available on our website within the next week. These web conferencing platforms are getting a high volume of traffic these days, as we all know. So please bear with us in case there are any glitches in the technology. On a related note, the film will not play on mobile phones through the webinar platform that we're using. So if you are joining us by mobile phone, I've put the direct link to the video in the chat box. So I would welcome you to step away from the webinar, view the film on your own in a separate browser, and then rejoin us for the discussion after the video. We ask everybody to please mute themselves. I think most people are automatically muted, but please mute yourself when you're not speaking so that we can limit background noise. That said, we do want to hear from you, and we welcome any and all questions, especially for our panel. So during the video, during the panel, please do submit your questions via the question function that you see on your screen. You can also email them to me if that is easier, and I will put my email address in the chat box as well. So with that, I'm going to turn it over to my colleague, Dr. Jay Gribble, our Deputy Director of Family Planning and Reproductive Health. Jay?
Thanks, Katie. Good morning and good afternoon. I'm pleased to introduce you to a new series that highlights why policy matters to good health. So often people go to the clinic or to the doctor when they need care. They get the medicine and the services they need, and their health issue is resolved. And that's great. That's the way it should work. But let's take a step back. What allows this all to happen? What about the treatment guidelines? Who employs the doctors and nurses and makes sure that they're qualified to care for patients? Who decides on priorities so that antenatal care, delivery, immunization, and contraception are available for people to attend to in the first place? What lays out how the Ministry of Health is structured and how civil society can play a role in influencing the health agenda? In a word, it's health policy. Operating behind the scenes, establishing quality programs based on international norms, mobilizing resources that pay for salaries and services, and ensuring the right quantities of medicines and supplies are ordered and on hand when needed. All these things that we take for granted when we go see a doctor or go to a facility don't just magically happen. They result from a solid enabling environment for health, which is why policy matters. Today, I'm pleased to introduce one of the experiences that the Health Policy Plus project has had the opportunity to support, and it highlights why policy matters to improving health. Kenya is a large and diverse nation. When advocates held President Kenyatta accountable for following up on an election promise about free health services, no one imagined that it would lead to a large-scale reform in health service delivery. But Linda Mama, which now covers antenatal care, delivery, postpartum care, and child care for 12 months, is now available free of charge, and it's working. Bold policies that serve the public are changing the lives of Kenyans and saving the lives of thousands of women and children. Through these policies, Kenya is on its way to achieving universal health coverage. I'm pleased to introduce our panel. Moderating today is Mrs. Regina Ombam, who is HP Plus Kenya and East Africa Regional Director. Trained as an economist, Regina has extensive experience working with Kenya's ministries and National AIDS Control Council and has served on numerous global health committees. She's joined by our panelists, Dr. Isabel Maina, who serves as Division Head of Health Financing in Kenya's Ministry of Health, where she's charged with developing the country's health financing policies, strategies, and guidelines. Dr. Maina has extensive experience in health system strengthening from the subnational level, where she served as a district health manager, to the national level, helping define Kenya's universal health coverage agenda. Dr. Pata, who appears in the video, unfortunately was not able to join us, but we're lucky to have Dr. Mercy Bruba with us, representing Mombasa County. For the past 5 years, Dr. Bruba has served as medical superintendent of Tudor Sub-County Hospital, a 20-bed facility offering outpatient and maternal and newborn health services. She's joined by 2 of her colleagues working on the front lines of maternal health care in Kenya, Mrs. Emily Mwaringa, Mombasa County's outgoing RMCAH coordinator, and Wanakarama Mohammed, the county's incoming RMNCAH coordinator. And we're also joined by Stephen Muchiri, Senior Policy Advisor for HP Plus, who led the HP Plus Kenya team that supported the Ministry of Health in the design and implementation of Linda Mama, which is Kenya's free maternity health program. Before we hear from our panel, let's take a few moments to watch the video and learn how free maternal health care in Kenya is saving lives.
Thank you, Jay. And I think everybody has watched the video, so I'll just go straight as a moderator of this session. And I'll start with Mercy. Mercy, as a medical superintendent of where the project happened, can you just quickly tell us what is this big change that Linda Mama has brought to maternal and child health?
Okay, I'm the medical superintendent of a sister facility to Portrees. We are in Tudor. And what we have experienced is, yes, we've noticed that there is this health-seeking behavior for pregnant women, for services, for skilled delivery services. This has gone a long way in helping us manage these patients and also handle emergency cases on time, hence saving babies and saving mothers.
Thank you so much, Mercy. I'll now go to Emily as somebody who has coordinated reproductive health care work in the region. And Emily, just let us know in your own way, in terms of realization of reproductive health care. When we watched the video, we were seeing issues to do with the integrated service delivery. What are those key things that you can actually let us know here that have actually brought a change in the way reproductive health care is delivered in the region? Emily, we can hardly hear you. Are you muted?
Can you hear me now?
Yes, we can.
Hello?
Thank you.
Okay,
We can.
sorry for that. I had a challenge with my computer, but thank you so much. As a county, I can say we've seen great improvement when it comes to deliveries. Actually, our numbers have been coming and increasing steadily. Up to now, our target is about at 7,500 women per year. And we can see we are reaching almost 93 of that target. So we can see with Linda Mama, we've improved in antenatal care services. More mothers now register through Linda Mama. And once they are registered with Linda Mama, they come for antenatal care and eventually deliveries. We can also see an improvement in family planning. We are seeing a good improvement in numbers because we started very low when we started in 2017. We are almost at 43 now when we look at our figures. And this is due to The mothers after delivery, after postnatal care, they're actually introduced to a family planning method. And this one has really improved on our targets. When it comes to children, after 6 weeks, they are normally given immunization, and that one has really realized our figures when it comes to actually children under 1 year getting immunization. So we are seeing a great improvement through Linda Mama. Thank you.
Thank you so much, Emily. Thank you so much, Mercy. I'll now go to Isabella. Isabella, as somebody who sits in the national government and has also been very key in looking at issues to do with health financing and universal health care. Following our president's Big Four agenda, where universal health care is one of them, the key things around universal health care are things to do with access, coverage, and financial protection. From where you sit, when you look at all that is being done in terms of Linda Mama program, what do you feel really comes out in the perspective of UHC that you could actually share with us here?
Thank you very much, moderator. Indeed, let me start by saying policy matters, as has been said. Policy led by the leadership of the country, led by His Excellency the President, and indeed in the country implementing universal health coverage as one of the government development agenda. Indeed, we say it's one of the Big Four agenda for the country. And having said that, this is enshrined also in our constitution that talks of the right to health. And Linda Mama was one of the programs initiated to move the country towards UHC, among many other programs. And looking at the tenets of UHC, there's the issue of access. Indeed, if we look at the mothers who are accessing delivery services before, during delivery, and after, the numbers have tripled, I would say. In the first year of implementation of Linda Mama, we saw a jump by 40%, for example. If we look at deliveries happening in health facilities in the last financial year, compared to the year before, we had 75% of mothers accessing deliveries in our health facilities compared to 62% in 2018. Meaning we have better access, which is a tenet of UHC. In terms of financial protection, I think the video has shown that 1/3 of Kenya women deliver at home. But from the number that we have seen now, that is reducing, meaning that mothers are able to access services, be it cesarean, as you have seen in the video, and all that. So the issue of financial protection, improving in health-seeking behavior, as we have said, access to other services like family planning. Overall, apart from what has been given in the country, we are talking about 62% of mothers being on modern methods of contraception. Access to neonatal and child health services. So very critical. Access to key infrastructure that is of quality towards delivery of quality services as one of the tenets of UHC. So broadly, the other aspect is that since Linda Mama was moved to one of the main strategic purchaser in the country, it was actually to enhance that journey towards UHC, improve quality of services, improve the issues of processes such as reimbursement as we strengthen our strategic purchaser, which is the National Health Insurance Fund. Thank you, Chair.
Thank you so much, Isabel. And now I'll come to you, Muchiri. We have listened to the people on the ground, we have listened to the policymakers, and now we are coming to you as somebody who has been doing a lot of policy work in the area of health. And you have always been inspired by evidence informing policy. So in terms of evidence generation, when it came to this whole project around Linda Mama, the modeling around it, what exactly did you do as a group? And whatever you did, how did it then inform this change that we are now talking about today?
Thank you, Regina. There are two things that we did. First and foremost is that In 2013, we finalized what we call the Kenya Household Expenditure and Utilization Survey. And that survey had two observations. One is that if you look at insurance coverage in Kenya, it was barely 20%, which was a concern to policymakers. And two is that 6.2% of the households were facing catastrophic health expenditure because of health, and 60% of those people who are facing catastrophic expenditure were women and children. So those two indicators trigger the discussion: how do we generate a policy that to ensure that we protect those vulnerable populations? And then two is that in the same year we just released the preliminary findings of the KDHS, and KDHS was showing that Kenya is losing 18 women through delivery every day. That translates to about 7,000 women. Another evidence that we use to let the policymakers know that we are losing our mothers and children and daughters because of things that can be able to manage. So the question was, how do we get a policy that will get those women out of that problem? And that's how the Linda Mama came to be. So those two evidence were used to change the discussions around creating that policy. And finally, is conducting a financial sustainability on how much do we require to be able to support the program, both from a Linda Mama perspective through NHIF, and we realized that we only required about $425,000 per year, and getting support from National Treasury to be able to factor that money in the budget.
Thank you, Muchiri. That was really well put. I'll now go back to you, Mercy and Emily, and this is where I ask you the big question. With all the good things that happened with Linda Mama, we started seeing demand for services increasing. And so everybody was looking at this as a good thing and moving in to get those services. What did you experience in terms of challenges from the supply side as somebody in that working in that sector? Mercy?
Yes, when it began, there was an influx of patients, of mothers seeking this. The biggest challenge was to sustain the services in terms of commodities and drugs, knowing that we were going to claim these monies from NHIF. And usually this takes some time before reimbursements are done. But thankfully, through the county, all this was expected, and we got a lot of support from the county itself through the Department of Health, whereby we had made our orders and we did deliver commodities to sustain this program when it began. Yes, thank you.
Thank you, Mercy. Emily, anything to add around this big demand? And there you are as a supplier asking yourself, how do I manage this demand?
Yeah, there was that challenge, and we really tried to intervene. And what Mas have just said, the hospital actually came in and ordered through their FIF, and the county really supported that. And we got some supplies to actually cater for those demands, which were actually created through that Linda Mama. And for family planning, the demand was so high, we even had to look for our neighboring counties to actually assist us with commodities. And that is how we actually intervened when we came up with the demand creation. And when the numbers were increasing, we had actually to cater for that. And we are really glad for that. Thank you.
Thank you so much, Emily and Mercy. So listening to Emily and Mercy, Isabel, I come back to you again. The issue of sustainability, as somebody sitting in the national level, when you look at such a nice program like Linda Mama, and you ask yourself, how then do we make it sustainable? What are the kind of things you would tell us here that could actually make us see this as a sustainable program? Because already the public has a lot of confidence and trust in it.
Okay, thank you, Regina. As I said, Linda Mama has been a program that has taught us in Kenya and shaped the roadmap towards universal health coverage. And since the country is now implementing overall universal health coverage, we are working towards integrating all the programs so that everyone in Kenya, whether the mothers, whether the poor, whether the rich, are covered through a social health insurance model. I know UHC, we had to start somewhere, start with the most vulnerable groups. And of course, in any country, the mothers and children are one of the groups that are vulnerable. But progressively, as we move towards the UHC journey, the roadmap towards sustainability is to ensure that is integrated in the overall social health insurance so that once everybody is covered and has a form of medical insurance, then all the mothers will be on board. Number two is that the government is mobilizing tax financing to ensure that the vulnerable in the community or in the country are covered. The mothers will not be able to pay for their insurance. Should we move from the Linda Mama aspect and move to the social health insurance, that the government will be able to take care of that. So that's a roadmap that the country is moving towards social health insurance. We have a transition phase from now and in the next 2 years, where the government is consolidating all existing schemes to be able to have a bigger pool and cover more and more Kenyans. Number two is working with the county governments to expand the scope of services, because as my colleagues who are in service delivery have said, the issue of quality of services, apart from just giving financial, assurance, we also need to look at the technical access and the technical availability of those services. So investment in the health system at the facility level is also happening. And indeed, just last week, the two levels of government have worked to see out how that will happen. The investment in the various facilities to ensure that there's continuous availability of services, be it Linda Mama or any other service towards UHC. Thank you.
Thank you so much, Isabel. Thank you so much, ladies, for very good responses. And finally, to Muchiri, I just want you to get us to know, in your assessment, as somebody who has done a lot of policy work, when you look at maternal and child health in this country, what is your dream?
I think my dream is to have, no woman die because while they're delivering. I think that's my dream. Okay, if we can have a zero death, at the point of delivery, that's my dream. Of course, that's a long-term dream. I think we need to do a lot of policy change to ensure that we get there. And I hope that Linda Mama will be a good program that will transition from as Dr. Maina has said, to UHC, so that we can be able to protect those women and ensure that they get access to health and they can go to deliver without any financial barrier.
Thank you so much, my panelists. You have really educated us this morning, afternoon, evening, and we are really happy to listen into what you have to say to us. So I now want to just push this over to the bigger audience so that we get to hear what they have to say, what questions, what comments they have, so that we can actually be able to make some decisions around what we need to do going forward. And I'll hand over to Katie to walk us through that session.
Hi, everybody. Thanks, Regina. So we've had a couple questions come in. So I'm just going to pull those up here. So one question from the audience is postnatal family planning compulsory for all women, or are women consented before getting family planning services after delivery? So maybe Dr. Mercy, maybe you could take that one.
Postnatal family planning, is consensual. So the clients are talked through it just after delivery, and if they decide that they would like to pick a method, that is when it's done, mostly 24 hours after delivery for the IUCDs in labor. And then for the ladies who come now for the second week postnatal checkup, which is also covered under Linda Mama, we still try to talk to them. The ones who are willing for family planning, they're given the choice, the method of choice. And those who are not, it's not a must. So it's basically what the patient chooses and after how the health education they've been given at delivery point. Thank you.
Great, thank you. So our next question is, what are the plans for Linda Mama now that the UHC program is being scaled up? Dr. Maina, I think you spoke to that a little bit, but maybe Dr. Maina and Mr. Muchiri as well. Any other plans that we want to talk about in terms of universal health care, either from the policy side or the health financing side?
Thank you very much. Maina here. As I said, Linda Mama continues for now, especially because our insurance coverage is still low. The journey towards UHC is progressive. So we really do not want the mothers to lose the benefits. So for now, for this financial year and probably the next financial year, Linda Mama continues. But by mid next year, there's already a plan to consolidate the Linda Mama program and the funding thereof into the overall UHC. The purpose that we'll have more and more Kenyans enroll into universal health coverage, because there are two things. One, there's that aspect of mobilizing funds through taxes. Number two, also mandating health insurance that is proposed, and the government, including cabinet, is working towards that. Thank you.
Thank you, Dr. Maina. Mr. Muchiri, anything to add?
Just to say that I think as Dr. Maina said, Linda Mama will continue in the medium time, but in the long term, the thinking is that there's need for some reforms at the house that is managing the Linda Mama, which is NHIF, to make it more efficient and to expand its coverage. As we talk now, I think the ministry has set up a team that is looking at the legal framework for reforming that NHIF. When that is done, and we start pulling all the funding into that pool, then Linda Mama will be phased out, and then there comes in a bigger pool that will ensure that we protect everybody, including the women.
Great. So I know that there was, a lot of evidence generation that happened to, to get the free maternity care program off the ground, and then, of course, then transferred to NHIF. Can you talk a little bit about just sort of the collaboration that happened to make that a reality?
Is that to me, Kate?
Yes, that's to you, Mr. Muchiri.
I think what happened is that immediately after the Jubilee government came in on 2013, this was identified as a problem. The high maternal mortality was a problem. And so HP Plus was requested by MOH to convene stakeholders forum to really figure out how do they address that problem. And we brought in, people from Ministry of Health, we brought in people from the private sector, we brought in National Treasury, and we brought in Parliamentary Committee. And we start to ask ourselves, how do we ensure that going forward, we are seeing a reduction in MMR? And two, how do we ensure that we mobilize funding to be able to support that program? So we set ourselves into several technical working groups. One was technical, to define the whole issue of the package that we are going to cover. The second one was looking at how we monitor the implementation. And the third one was on financing. So three thematic groups sat, and each of them where HP Plus was prepared a report which we presented back to the Cabinet Secretary for Minister for Health. And once he adopted, he took it to Cabinet. Cabinet approved, and then Treasury was requested to earmark funding to support the program. So a lot of work went on, a lot of evidence went on, a lot of consultation went on, including also stakeholders to ensure that we are able to develop a program that can be sustained financially and technically.
Thank you. So we have a couple more questions that have come in from the audience. So Dr. Mercy and Emily, I'm going to direct this one to you. Someone is asking, are women using all services offered under Linda Mama? Is there an increase in service utilization for ANC and PNC2?
Yes, from the facility level, I can say the Linda Mama package, the one that covers it has 3 phases: the antenatal package, then the delivery package, and then there's the postnatal package that covers the women post-delivery 2 weeks and then 6 weeks postnatal. So yes, our clients are aware of the services available with that same card, and they do come for these services. The word has spread, and actually when they come for their ANC services, we sensitize them some more about the delivery package, and then after that, postnatal. Thank you.
Thank you. Emily, anything to add to that?
Yeah, what Master said is true. For the facilities which maybe don't conduct deliveries, they normally enroll the mothers through the antenatal care, and then they go for the delivery package in the facilities where they conduct deliveries. And from there, they're actually introduced to the postnatal, and then they get the method of choice through counseling, and they just have to make their own informed choice for the postnatal package, and then maybe get a family planning method for them. Yeah, thank you.
Great, thank you. And Dr. Maina, somebody's asking, they'd like to know a little bit more from the experienced panelists. On average, how long does it take to develop and implement a policy such as Linda Mama?
Okay, said policy matters, but I also want to add that leadership and governance matter. As long as you have the right leadership, it takes quite a short time, because it's just putting the thoughts and policies in mind onto paper and implementation. Luckily for Linda Mama, as has been said by Muchiri, it was one of the campaign promises or one of the manifesto of the government of the day. So immediately the government came into place. There was just a presidential declaration, and the ministry, therefore, with the partners like HP Plus, developed all the necessary guidelines and all that. So I would say it can be as short as much as is support by the leadership, whether at the ministry level, whether at the implementation level, and all that. Some other policies in many other countries, and not necessarily Kenya, takes years and years because of lack of the relevant support. Yeah, thank you.
Great, thank you. So the last question I have here is, what was the level of involvement of communities in the Linda Mama program, given some communities are reporting home deliveries? So was there a level of community engagement and community involvement in the policy development and implementation? And I think that's probably the best directed towards Dr. Maina and also Mr. Muchiri. But I welcome anybody to jump in.
Let me jump in. Sorry, go ahead, Isabel, go ahead.
Okay, let me start, and then Muchiri will fill in. Being younger than me, I'm sure he'll help. So for any policy development in the country, we involve all the stakeholders groups. We have consumer groups or the CSOs represented by their umbrella body in the country. So involvement is there. Number two, for Linda Mama, a lot of communication, a lot of awareness in the communities. If we go down to the facility level, there's representation of the communities through the governance structures at that level to ensure that there's engagement of community even as they provide the services. So for any policy development in the country, do involve all the stakeholders, be it funding or development partners. But Muchiri can add that. Thank you.
I think in this case, because there was a political push, first of all, we started with the free maternal services, which took, elections happened in March, and we were required to ensure that by the time the financial starts in July, there's a policy document. So you had only 3 months window for us to be able to do the documentation of the FMS policy. And what we did is that because we didn't have that luxury, that time to engage the communities, we engaged facility management committees where communities are represented, and from them we were able to get their voices. In terms of transitioning from FMS to Linda Mama, we had also about 6 months window for us to be able to transition. In this time we were lucky because counties were present, so we engaged communities through the county platform, and we got their views on exactly what we want. We were able to do an exit survey to find out, what are their preferences at the community level, and we use that information to be able to package Linda Mama documentation.
Great. Thank you, Mr. Muchiri. And then one more question before I turn it back over to Regina. I believe this, trying to read the question here. So how did the Ministry of Health address initial hiccups with the implementation of Lint and Mama? Things rarely work perfectly from the first try. So what did the ministry do to assess progress and make adjustments? Dr. Maina, would you like to field this one?
Yes, I will take that one. The ministry, initially, as was said, the program was run under a department in the ministry. So continuous follow-up, collection of data, assisting counties with guidelines, assisting with clinical guidelines, supervision, and all that. Indeed, after 1 year of implementation, there was a survey that was carried out, showed the good numbers, as we have said, the 40% jump. But we also realized there was a challenge in terms of quality of care, and basically not because of the skills, but maybe because of lack of the relevant or necessary equipment. And therefore a plan then in the budget to ensure that the county facilities are equipped accordingly. And also then, as has been said, we are in a devolved system of governance. So engagement with the subnational level to critically discuss all the programs, including Linda Mama, and coming up with action points for implementation, including availability of skilled health personnel, which is a county function, training by the national government, equipping by all of us as stakeholders. So we do have reviews and remedial measures, including annual reviews and quarterly reviews with the counties. Thank you.
Great. So we had a couple more questions coming in. People are very active in the discussion. I love the enthusiasm here. So another question to our Mombasa County colleagues. Are there any estimates of how much it costs at the county to provide Linda Mama services to one woman?
I'll take this up and then Emily will complete it. So for a delivery in Chuda, a normal delivery costs us around 7,000, and a CS procedure costs us around 10,000. Linda Mama reimburses us 5,000 for delivery and 5,000 for CS. For antenatal clinic, that's where we are benefiting the most, whereby the first visit, which includes the ANC profile, That one, Linda Mama reimburses us 1,000 shillings for the first visit, and then 300 shillings for every consecutive visit. Initially, we used to charge 500 shillings for the NC profile, meaning the first visit, and then our mothers never used to pay for the consecutive visits that they had in NC clinic. And then for postnatal, we didn't used to charge for those services. So Linda Mama is paying us 250 shillings per postnatal visit. So that's where we are benefiting the most. Maybe if Emily has anything to add. Thank you.
Yeah, Mercy. For the hospitals, that is the charge. For the facilities, the charge first visit 600 for antenatal care, and for the subsequent visit, they charge 300, and postnatal care as well 300. So actually, for the lower facilities, they are benefiting even more, because for level 2 and 3, normally we are not supposed to charge anything for the mothers. But with Linda Mama, they're actually collecting that money, and they've been improving their facilities very well using the same funds. They've been restocking their facilities with commodities using that fund. So actually, those are the changes which actually imply and actually being used in the lower facilities. Thank you.
Great. So another question to Dr. Maina. Can you tell us more about the role of the private sector, if any? As policy is reviewed and revised, is there a growing role for the private sector providers? Dr. Maina? Oh, she appears to be frozen. Mr. Muchiri, would you like to jump in at all while we try to get Dr. Maina back?
I will try. I think when we designed the FMS, the free maternal services, the reimbursement were only going to public facilities. But then when we did the evaluation in 2016, women were demanding a choice because they felt that they are being limited and they are being confined to public facilities where most of them didn't like the services because there were shortages of supplies. Sometimes there were no human resource, and they asked, can we be given a choice? So in the designing of the Mama, we opened up and we brought on board the private sector. So the private providers are part of the Mama program, and they are reimbursed by NHIF the same amount that goes to the public facilities. So that's how we brought in the private providers to bring in the need of the women.
Great. It looks like we have lost Dr. Maina, but hopefully we will get her back. So my last question was to her. So Regina, do you have any other questions that you would like to pose to the panelists?
Thank you, Katie. I really don't have much to ask the panelists apart from now doing the last bit of this discussion, asking each one of them for their parting shots. So if there are no questions from your end, I'll take that on so that I ask them to give us their last parting shots based on a question that I might have for them.
Great.
So I'll take this on, and I'll start with Mercy. Mercy, I'm looking at you as a leader, and I just want you to tell the audience today, as a leader, as a mother, what would you like us Kenyans to do as we think about saving the lives of mothers and children in the context of COVID?
Thank you. This Linda Mama policy has been so beneficial to our mothers, especially where I work. We are in an area surrounded by slum. We are surrounded by 3 slums, and I have seen women benefiting from this package and the policy that is in place. So what I would like to say is when UHC picks this up, let's not forget that this is very key. We might want to have universal health coverage for all the other services, but I feel like maternal care is so key because losing a mother during delivery is quite a painful event. And the reimbursements, the biggest challenges that I've had actually in managing a facility like this one is just the fact that the monies take a bit longer from NHIF to come in, but they do come. And that is the only reason why we've been able to sustain the services that we have, by having enough commodities and drugs. So I personally believe that this was a very good policy, and we have so much more to do. And thank you. I think that's all I have to say. Thank you.
Thank you, Mercy. You've really brought a good point that for you to be able to work, there must be enablers. And one critical enabler is the financial stability that you need so that you're able to deliver that service and still make sure that mothers are confident enough to walk into your facility and leave there saying, I got the best service that I wanted. So I'll go to Emily now, and I look at you, Emily, and I see the power in you. And I just want to ask you one little question. You get into the lift and you find the governor of Mombasa. What will you tell him in 3 minutes about saving the lives of mothers and children?
Well, okay, thank you, Regina. What I would really ask the governor to say is that lives of the mothers matters a lot. And for a community to actually grow and have healthy families, we need to protect the mothers, especially the expectant mothers. So we need to support the mothers financially. We need to support the mothers when it comes to service delivery. And our governor is very key. I'm sure he listens to that. Thank you, Regina.
Thank you, Emily. I see how you want to get the political class to really get this agenda moving. And I like the way you said you'll be with the first thing you'll tell him is, please follow the dream and make sure all mothers and children are safe when it comes to delivery. Muchiri, as the man standing in between all these women in this panel, and you gave us a very good indication regarding your dream, where you would really like to see mothers deliver safely and children live to see even their first birthdays. As you look at the political class, as you look at the leadership and the governance that we have, what would you really get us into perspective as we think of the next set of leadership in the health sector? What would you really get us to put into focus as we talk about maternal and childcare?
Mr. Muchiri, I think you may be muted.
Sorry, are you muted?
Sorry, yeah, sorry. I was saying that, you know, 3 things. First and foremost is that we need to continue the advocacy, because leadership, policy makers come and go. And as people in the health sector, we need to ensure that we continue with advocacy and that targeted messaging to ensure that we are able to save those 7,000 women that we are losing every year. 2 is that we need to show, you know, some returns on investment, because remember, the Treasury is investing this money, and sometimes they see us health as consumers. So we must ask ourselves, how do we, from this policy, show that whatever money that is being pumped by the National Treasury, we are showing some returns on investment? That's very, very important. And we need to quantify that in a number form. And finally, is that we know that we have got a parliamentary health committee, we have got National Treasury. Let's continue, you know, getting them to appreciate this as a problem. We may not solve it tomorrow, so they need to support us going forward, and they need to support us both in terms of budgetary provision and on the implementation.
Thank you so much, Mr. Muchiri. Thank you, Emily. Thank you, Mercy. We missed Isabel. I don't think she's back, but I really want to thank our panelists this morning, afternoon, who have done a very good job. And so I'll take this back to Jay, who opened up to just close the session for us.
Great. Thank you so much, Regina and panelists, for a really insightful conversation about the Linda Mama program in Kenya, how it's developed, how it's implemented, but most important, how it is really changing the lives of women and children in Kenya and improving statistics, reducing maternal and child mortality. Thanks so much to our panelists for their insights, to Katie, who has organized this event. We hope that you'll stay tuned. We had a watch party recently on our Nigeria experience, and now this one on our Kenya experience, and really trying to reinforce the importance of health policy in improving the lives of people around the world. So thank you so much for everybody who took time today to participate and join, and we look forward to seeing you next time. Thanks.
Thank you all and good day.
Thank you.
Thank you, and bye, everybody.
Bye-bye.
Bye-bye. Thank you.